Hello and welcome to Lessons My Patients Taught Me. I'm your host, Dr. Elliot Davidson, a family doctor, coming to you from finally warming up northeastern Ohio. On this podcast, we talk about the lessons that my guests and I have learned from our patients over the years, those memories that shape how we think, how we practice, and certainly how we teach. Today, I'm really excited to welcome someone I've been looking forward to talking with, my new friend and colleague, Dr. Jennifer Baccon. Dr. Baccon wears a lot of hats. She's a beloved teacher at Northeastern Ohio Medical University. She's chair of the Department of Pathology there, and she's also chair of Pathology and Laboratory Medicine and medical director of the Values Analysis in Supply Chain at Akron Children's Hospital. Now, I'll be honest, this is a first for us. I haven't yet had a pathologist on the podcast, let alone a neuropathologist. And I have to say, some of my favorite teachers in medical school were pathologists, the ones who could take what seemed abstract and make it come alive. Now, that's kind of weird to say about pathologists, but it's true. And from everything I've heard and now experienced, Dr. Baccon is exactly that kind of teacher. A little bit about her background. She did her undergraduate work at Cornell University, spent time at University of Oxford, then completed both her MD and PhD in cell and molecular biology at the University of Pennsylvania. She stayed at Penn for her pathology residency and fellowships, and later she earned her Master's of Healthcare Management from Harvard University. Her career spans teaching, leadership, research, you name it. She's taught across disciplines from medical students to neurology and neurosurgery residents, published extensively and led at very high levels. In short, she's one of those people who's doing a lot of important work, and she still finds time to teach and connect. Jennifer, it is a real pleasure to welcome you to the podcast.
Elliot, thank you so much for having me on the podcast. I'm looking forward to our conversation today.
Absolutely. Now, let's just start at the beginning. Tell me a little bit about yourself, where you grew up, and how did you find your way to pathology?
Well, I was born in New Jersey, lived briefly in California, but by the time I started kindergarten, my family had relocated to South Central Pennsylvania in a town called York. I went to public school there, always loved academics in general, particularly math and science. Did a lot with music, found myself on some sports teams now and again, but it was really during college where I found my love of science and medicine. I went to Cornell as an undergrad and had a fantastic time studying biology, learned more about what happens at the whole animal level as well as the cellular level during some time at Oxford University, then during a research summer at the NIH. I always have tried to get involved in things that sparked my curiosity. Through all of those experiences as an undergrad, I decided I wanted to go to medical school, but not just do the medical piece of it, also pursue a PhD in cell and molecular biology. Through that experience, I ended up at a research laboratory where I happened to share a bench with somebody who was a pathologist and found that this career was going to allow me to both think about the medicine side of things, but also the scientific side of things in a way that was going to be hand in hand on a daily basis.
Wow, that's fascinating. Now, you've worked in a pediatric pathology setting, focusing primarily on neuropathology and I guess kidney pathology. So, what drew you to that niche, and was there a moment or mentor that shaped that path?
I'll take you back to that laboratory experience while I was working on my PhD thesis. I shared the bench with a neuropathology fellow. He was finished the clinical portion of his training and doing some postdoctoral research. One day he said, "Why don't you come along to one of the clinical conferences that the neuropathology fellow is presenting?" And I went to the conference and really found the topic fascinating. Phenomenal thinking about what goes on in the human brain, what people were seeing under the microscope, and how all of the parts and pieces interacted. I tend to be drawn towards things where we don't know all the answers. And in the neurosciences, that's definitely a field where I think there's still more questions than answers. The postdoc at the time, Zissimos Morelatos. He is now the vice chair for neuropathology at Penn and really had served as a mentor in those initial phases. Also, during my training, I met a number of other neuropathologists, some who are really notable nationally, Jeff Golden, Alex Judkins, Lucy Rourke Adams, and others that helped shape my love and interest for the field. The pediatric piece of this came in perhaps a little bit later in my career. I, after training, took my first job at Penn State Hershey College of Medicine, Penn State Hershey Medical Center, and was doing neuropathology, some renal pathology, and then when had the opportunity to take on a chair leadership role out in Ohio here at NeoMed and the Akron Children's Hospital, that was when the true pediatric focus came into my practice. In my prior roles, I had done adult and pediatric, both neuropathology and renal pathology. Maybe looping back around to the renal pathology piece, that was an additional element of my training. I had graduated the fellowship in the time when there were a lot of hiring freezes back in the real estate bubble in the 2008-2009 era, and was trying to figure out what the next step was in terms of career. I had a great opportunity to stay at Penn to do a surgical pathology fellowship. And the thing that interested me the most, in addition to neuropathology, was the renal pathology or medical kidney piece. And let me tell you, between the two of those, I've got a decent amount of job security because those are two areas of pathology that not a lot of people gravitate towards. Relatively small numbers of people in both of those specialty areas. But they were areas where I felt I could really connect with the medicine behind the pathology. And I know we might talk a little bit more about this as our conversation goes on, but being a pathologist to me is not just at the microscope, but it's taking care of our patients and our community members. That's really important. And in both neuropathology as well as medical kidney, you have to really think about the medicine behind what you're seeing under the microscope, because you can't put the whole picture together just by looking in the scope. I need to understand the clinical picture. I talk to nephrologists and neurologists, and neurosurgeons, neuro-oncologists every day. And that for me is the glue that holds together the interest around those particular specialty areas.
Yeah, that's fascinating. It takes me back. I had a phenomenal teacher of neuroanatomy, Ted Venida. I don't know if you ever met Ted or heard about him, but he was one of the early founding teachers at NeoMed. And not only was he an animated professor, but he would act out different brain lesions, and he could do the different problems that people would have related to those lesions. And it was just so memorable the way he would do it. These teachers can have such an impact. You're clearly a gifted teacher. So many students have mentioned how much they enjoy working with you. Your learners seem to love you. What is your approach to teaching? What do you do that you think really works with students?
I always try to meet the student, the learner, where they are. I know along the way, I've been fortunate to be able to be a good test taker and master concepts. But in my own personal journey, I know that I don't always learn the same way others around me learn. And I think acknowledging that and trying to understand where each person is in their educational journey is a really big help to connecting with the students. It's not, for me, it's not just going into the classroom and giving a lecture and hope that some of it sticks. But I've spent a lot of time in my career understanding the pedagogical approaches behind education that are scientifically proven to be the most effective. And I try to apply those in any way that I can. And then, as I said, making it individualized, getting to know students. It's hard to do in a classroom with 150 or 200 students. But sometimes in those conversations during or after class, you start building the seeds of those connections. And it's really fun and rewarding to me to mentor those, particularly those who might struggle a little bit more, in helping them to look at the learning process in different ways that will help them to be successful. I love sharing my knowledge and my excitement, not only about pathology, but medicine in general, and being there for them when they have questions about studying for the test or as they're making career decisions, I think brings all of the pieces together. I'm flattered that the students enjoy the educational experience that I help deliver. It's not me alone. It's really a whole team, especially at Neomed, behind the scenes, making all of the parts and pieces come together in a cohesive whole to set our students up for success. And it's so nice to see that develop.
Yeah. Now, you mentioned this earlier about your interest in the clinical side of things and help you piece together the pathological side of things. In a field where you don't always meet patients directly, what are some lessons that you've learned from cases or from your work in the lab that have stayed with you?
There are moments where I feel isolated from the clinical piece, and there are moments where I feel really connected. Understanding the story behind the patient is really important. And as a pathologist, I not only look at biopsies under the microscope, but sometimes I'm doing post-mortem examinations. And some of those have surprised me. One time I remember a spouse calling up the department and said, "Hey, I think I know what's going on." And without that input, we probably would have missed the true diagnosis. Also, when I'm at the microscope, the thing I find myself saying is, this patient really deserves a good doctor. Focused on that, because I remember all of the times in medical school where I was face to face with the patient and their family. And I think all of us, we sit on the other side of it too, as patients ourselves from time to time. And remembering that the slide is not just a slide and part of my daily work, but the slide represents somebody's loved one, their child, their parent, their spouse, their significant other. And it's just, for me, it's very impactful because it's my way that I both find interest in my career, but it's my way to give back to the community and to take care of the people that are our neighbors. I think that's a special thing. It's not something that everybody realizes about pathology. We, as pathologists, see the patients as our patients as well. We often don't have the privilege of meeting them face to face, but I can guarantee you the pathologists are sitting behind the microscope or looking at laboratory testing quality controls and thinking about how the work that they're doing is going to impact patients and their care.
Yeah, I worry that looking into a microscope is going to become a lost art. It's something I think I'm the only one in my residency program that does it anymore. I keep trying to teach the residents and the medical student that it's almost like, when you look into a microscope, you're going into another world that we don't normally see. And it gives you information that you can't get another way. And oftentimes I can give the patient a diagnosis, whether it's, vaginitis or whether it's, urinary tract infection or whatever. I can make that diagnosis in the office. I don't have to send out to the lab and wait, get the test results back. And then, so when they go home, I know what's wrong with them. I can treat them, but I can't seem to get the learner interested in doing that at the point of care. And I wonder if you see that at the medical student level, at your level, at the first and second year level, they seem like they probably are okay with the microscope at that level, but something happens.
You bring up a number of interesting elements in that example. The first of which is the microscope itself as a tool of the trade. As we get more and more technologies, pathologists too have this, I'll call it a tango back and forth with the microscope. It's been historically the thing that we use in order to create the diagnoses. Digital imaging technologies, affectionately called digital pathology. We can scan slides and have those elements available to the pathologist in a remote type of fashion. So there are pathology groups where some or all of the pathologists will receive scanned slides via computer, their VPN connection, and do the diagnostic piece remotely. So the technology is both helpful if you need to staff far-flung laboratories that need the expertise of looking in the scope, But you balance that with the need to train the future generation of pathologists with the skill set. And that's a big national conversation right now. How do you balance needing the learners to sit at the microscope and embrace the historic technology while also being able to use and understand and being able to manage the more advanced or contemporary digital pathology elements? And so, as with many things, we're not fully along the route for that journey yet. I think we're probably not just at the beginning, but somewhere in the middle. Getting med students and other trainees to want to look in the microscope, yes, that's difficult. I think sometimes in our medical education years, the focus is really on the boards and passing a single test. And so, can I memorize a couple of images? But as you're illustrating, it's not just pathologists, but other physicians as well who can incorporate some of these diagnostic technologies in their daily practice in order to take great care of patients. I worry that if we get so siloed that we lose that richness, the pendulum will swing a little bit too far the other way, and we'll need to dial it back. As we see these technologies emerge, however, part of that pendulum swing has already started to occur because we've got so many digital pathology and other advanced technologies that we can use in the practice of pathology. Yet some people now recognize that, oh, yes, we do want to be at the scope, learning how to do it, because there's an element that if everything swings towards the technological aspect, we lose some of the bread and butter, the core skills and knowledge that we still need as pathologists. And I think for me, the most interesting part of this is figuring out how we're going to educate people to practice in this changing and evolving environment. So I don't know if I've got a great answer for you on how you get the learners excited. I think one of the things we always say in education is assessment drives knowledge. We don't necessarily assess their skills in sitting down at the microscope, and arguably not everybody needs to be able to do it. But I think having the appreciation for what others in different fields of medicine do in order to contribute to the holistic care of our patients is an important piece of the puzzle. I don't know if we've hit it exactly right. Some institutions probably do it a little bit better than others. It's definitely a complex chat.
Yeah, you bring up another point, and that is, when you're doing digital images, that kind of is a thing that AI could possibly do, like for X-rays, CT scans, et cetera. And I wonder, we talked about this a little bit when we met, from your vantage point about AI, what concerns you about where AI is taking medicine and medical education, and what excites you over the next, let's say 5 years? It's hard to predict any further than that.
Yeah. I I think what concerns me is that our systems, both in hospitals and healthcare systems, as well as higher education environments, are not as fully equipped to manage the AI interventions as our students and learners are able to incorporate them to their advantage. So, for example, I guarantee you most, if not all, students are using AI to generate questions for themselves on helping them to study for boards and their courses in medical school, residency. I think we're lagging a bit behind as educators, still focusing on more traditional methods, and getting the whole process of the education piece tends to be slow in terms of curricular change because you've got to plan a year or two ahead of time. You've got to get permission from the curriculum committee of all the methodologies and the content, the learning objectives. At the rate AI is progressing, the students have and use these technologies in order to better their education before we're able to incorporate it into what we're delivering. And the next thing I'll say, perhaps is a bit controversial. The way we deliver medical education is through folks like you and me getting up in front of the class and delivering content. And every single medical school across the country, across the world recreates that deliverable with their own faculty. This loops back to what we started our conversation with, which is the individual attention you can give to students. If you make everything online and prepackaged, you lose some of that. But at the same time, you can gain some efficiencies in the content that's created. Something that I reflect on frequently is that most of the media content and educational content we have access to in our world is really highly produced and easily accessible. And when we bring students into the classroom, we sometimes deliver a product that is very rich in content and accurate, but required a lot of work, again, by each individual who's teaching. I'll use my example. I teach some neuropathology basics. Every neuropathologist at an academic institution across the country is creating that same type of content and delivering it. And I just kind of wonder from time to time how we can get some of the economies of scale while still maintaining that individual attention to our students. In fact, I wonder if we might be able to better attend to our students if we can use some cohesive content more broadly, because the students themselves are looking towards now third-party resources, which always create this bit of a battleground. So I think that's one of the concerns about some of the technologies in AI. But AI can bring a lot of really amazing things. If I look at pathology and diagnostics, I know this takes us a little bit away from the educational focus of your question, but there are ways we can leverage these tools in order to do better in terms of diagnoses. In pathology, a computer can read pap smears and then present the abnormal cells to the technologist and then the pathologist. Same thing in looking at blood smears. If you're looking for abnormal white blood cells, there are machines that scan the slide, present all of the white blood cells categorized to the technologist. They then review it, can adjust it, and send the concerning cases on for pathologist review. So there are elements of AI that are already baked into our daily practice. And some of that's computer. What I'm talking about is maybe not fully AI, but computer-assisted diagnosis. I think what we have to be careful about, been written on extensively in some of our major medical journals, is how do we govern the use of the AI making the decisions for us? And that's where I think technology is moving fast, and I'm hopeful that we as the profession of medicine can still keep some constraints around what we allow a computer to do in replacement of us, because I think there's still a period of time here where we need to have proof of concept that if we hand over certain diagnostic elements to a machine where there's no double check, we might do more harm than good. And I think that's one of the warnings or cautions. Yet at the same time, as we see our population grow, the amount of healthcare that we can deliver grow, yet have a static, or in some fields and professions, a declining number of physicians and other healthcare professionals, we almost have to use some of these technologies in order to continue to provide the care that's needed and expected from our community.
Yeah, well, very comprehensive answer there. I appreciate that. You made me think, Khan Academy was something that the kids used to learn math, and really great content that anybody could tap into for free. There might be something similar for medical school. And what you could do is learn it asynchronously and then have the professors there to discuss cases based on content that you've already learned. That would make a lot of sense to me as, the pre-recorded content you were talking about. And now with AI, we've had a couple of podcasts on that already, and we've talked about the fact that for now, still need supervision by humans, still need humans to take the liability risk. I don't think people are going to be able to sue AI yet. Someone's going to have to take responsibility for the AI output. But we'll see where that takes us. It may eventually, AI may achieve its own agency and its own bank account. We'll see. I want to tap into your vast knowledge and hear a little bit more, maybe just for perhaps about a case in neurology, a neuropathology, or a case in kidney disease that would kind of flesh out some of your experience for our listeners. Can you share something?
Sure. So I'll take muscle biopsies as an example. So muscle biopsy is one of the areas in neuropathology, maybe a bit of a niche area even within neuropathology. Looking at muscle and associated nerves allows you to peer into so many different things in terms of medical diagnoses and genetically inherited conditions. For me, that's one of the areas that brings together so many of the different technologies that we use. When I look at a muscle biopsy, we get a piece of tissue. We need to technically handle that piece of tissue in specific ways. If we get scientific about it, we need to keep that piece of tissue cold in order to do some of the histochemical stains, which basically allow us to peer into the cell and see the actual cellular reactions happening via an indirect color reaction. We freeze the tissue in isopentane cooled by liquid nitrogen because it allows the muscle to freeze at a rate that gives us the most pristine view of the tissue. Again, the details are not important, but the thing is there's all of this scientific richness behind what we do in the laboratory that I think is sometimes not really known. On my good days, I don't even need it to be appreciated, but there's a wealth of knowledge that we can bring to the table to help make sure that it's not just that the tissue's handled in the appropriate way. So then when I get the slides to look at, I get a tray of slides and we put 20 slides on a tray, standard. And I get to look at all of these different chemical reactions, in a sense, on the slide. I see our traditional H&Es or the hematoxylin and eosin stains, but then another 10, 15, 20 different kinds of stains that allow me to look at different things, how ATPase is functioning in the cells, NADH, SDH, cytochrome oxidase, all sorts of other elements that allow me to see fast twitch and slow twitch muscle fibers, what's going on at the subcellular level. And then as I have more questions, I can use electron microscopy to look down at the myofibrillar architecture because some diagnoses don't even make themselves apparent on the slides themselves when we're looking at, you know, I don't know, 200x, 400x magnification, but we need to go up to 10,000 or 20,000x magnification in electron microscopy in order to find the etiology of a patient's muscle disease. But that's one of those areas that I also need to think about the entire medical history. What medications has the patient been on? When did they stop those medications? What are the symptoms that they're presenting with? And in proximity to the biopsy timing, how does that all interact? Because all of that changes the diagnosis. So if somebody has what's suspected to be an inflammatory myopathy, so inflammation in the muscle caused by either sort of an idiopathic type of disease starting, or because something else triggered it, a medication or otherwise, autoimmune disease, etc. I need to understand what that patient's been treated with. They got steroids to treat the inflammation. Those steroids work. And when I see the muscle biopsy, I have to then look at indirect means to try to figure out what happened before the inflammation went away. So for me, putting all those pieces together is both fun and rewarding. And it's nice when you can take a scenario of somebody who's presented with muscle weakness in their 50s or 60s, and you don't know why. And then you can take a look under the microscope and you can give that person a diagnosis that hopefully can be treated. But if not treated, understand what that process is and what the prognosis and trajectory looks like. Again, I never get to talk to that patient face to face, but that's what I'm thinking about when I'm working through a case. The other thing that that muscle biopsy example illustrates is that it's not necessarily simple or overnight when we have an answer. Sometimes it may take days to weeks because of the technical performance of the stains, of the electron microscopy. Sometimes things need to incubate or fix for periods of time. And to be able to put all those pieces together so that we have the right answer and not just an answer, I think is something that I would hope people know and understand. Again, as I mentioned before, many of us have been on the other side of this too, where you're waiting for an answer. And let me tell you, the pathologists are thinking about trying to get those diagnoses out as fast and as accurately as humanly possible.
Yeah, you brought something to mind I hadn't really planned on talking about, and let me know if you're okay with it. My father died in 1973 when I was 14, and 1978, so 5 years later, I was a medical student dissecting a human body in anatomy lab. Pathology teacher, my anatomy teacher at that time was Norm Taslitz, who spoke to us about the sacredness of that experience and going into the anatomy lab and the privilege that we had of doing that. And that was actually a very hard experience for me. I didn't talk about it much at the time, but I wonder what it's like to do autopsies and that experience for you as a pathologist. You were in charge of an autopsy lab at one time. Could you talk about that a little bit?
Sure. Well, thank you for sharing your personal story as well. I think as humans, it's just tough, right? It's tough for pathologists too. It's not like we're made of some other substance that allows us to do this without feeling. I think there, as with many areas of medicine, there is an element of kind of partitioning off what you do as a technical performance of an autopsy from the way you live the rest of your life, because it is heavy. It is weighty. I've had many colleagues who really don't want to or sometimes can't go through with something if it hits a little bit too close to home. They'll walk out of the room. Sometimes, and usually that's during the training phase, when you're in charge and you are the attending pathologist for anatomic pathology, it's your job. I think in the training phase, that's when a lot of people learn what they are and are not able to do. Folks who've lost a child almost universally can't go in, perform a postmortem on somebody who would be in that age group, right? So it's a very difficult topic and it's a difficult time. There, the performance of the autopsy is also just like looking at the muscle biopsy. It's a discovery process and it brings that curiosity piece into it too. Over 30% of autopsies performed still today, even with all the advanced imaging technologies, over 30% show a major contributor or a minor contributor to the cause of death that was previously unknown during the person's lifetime. And that's valuable. That's valuable for closure for the family. That's valuable to understand maybe risk or prognosis for other family members. And what we've seen is it helps, right? It can be a real piece of the healing process for the survivors. And one of the things that I think I was most proud about in running the autopsy and decedent care services at Penn State was that on occasion we would get notes from family members in the community saying, wow, your team helped make the most difficult time in our lives one of the sort of, the easiest to navigate in that regard. And when somebody has lost a loved one and writes a note back to the health system saying, hey, you helped make this tolerable, you helped make us whole as we went through the process, that's human, right? That's the caring that brought us all into medicine. I know I keep doing this contrast because I enjoy getting out there and talking about pathology and sometimes the perceptions or misperceptions of pathologists. We're friendly, social people who
Some of
went
you are.
right, who went into medicine because we want to heal and we want to help. And there are different ways to do that. And one of the ways is through providing closure and information at the time of death. Some of those ways are providing diagnostic information on those biopsies. And some of the ways are making sure that every lab test, like a blood count or a chemistry panel, not only gives you an answer, but the right answer. And so that patients can be treated well based on the results that we issue, because we know how, as physicians, we know how important all of those different elements are working together. So I hope I've answered your question about, what it's like in the autopsy suite and how it relates to our care and our care of patients.
Anything else you want to share? A lesson, a story, something you wish more people understood about pathology?
Well, I like to think we make a lot of the magic happen in the health system. The pathology department, first of all, you need a laboratory in order to have a hospital. It's a CMS regulation. That laboratory can have different scope and scale, but it's a critical component to what we do in the practice of medicine. Some sources quote it as over 70% of all medical decisions are based upon results that are issued by the laboratory. And I think that's pretty impactful. We're not often seen out front. I only know one pathologist whose picture was on the side of a bus or a billboard, but we're part of the team. And I would just hope that our medical colleagues utilize us consultants as sounding boards, as fellow practitioners, where we can bounce ideas off of one another, really talk about the care of the patient. And it doesn't just have to happen at tumor board, but it can be anytime somebody has a question. Something that I think not everybody realizes is that when you're trying to debate, like, which test should I order? Kind of guessing and ordering it, might not be the best idea. But if you give the pathology laboratory a call, we've got experts who did residency and usually multiple fellowships who can and want to help advise which tests are the right tests for the patients. And then also downstream, let's say you get a result back that's kind of confusing because it was an esoteric test. Maybe you don't order it that much. We're also here to help explain and guide those next steps. And now that you have this result, what does that mean? And what might we do for the patient in terms of treatment or next steps? So when I was reflecting on coming onto this podcast, and another thing sticks in my mind. This was from my residency training. Somebody came in demanding to look at the slides on their patient, and I had a stack that was a couple of feet high on the desk, a few stacks. I said, it's going to take me a moment to find it. And the other person was incredulous that I had more than a case or two sitting on my desk. Pathologists are busy. They work hard. It's intellectually demanding. And it's not sitting behind the scenes and just sort of being there. We're at the microscope all day, every day on the anatomic pathology side. We're running the clinical laboratories, not pipetting and doing the tests, but we're making sure that all of the quality controls for the instrumentation are accurate. And so it's something that I wish more people could have the opportunity to see. So if you ever get a chance to take a tour through a pathology laboratory and visit your pathologist in their environment, I bet they would be delighted to share with you, even in a 5 or 10 minute conversation, what their day is like. Because I think there's this sense that, it kind of it's so behind the scenes, nobody's quite sure what you do with your day. When we had the COVID pandemic, that was the first time where really the whole world, I think, realized what pathology is. And maybe the pathologist piece wasn't connected entirely to the testing, but everybody knew what COVID testing was, right? And everybody knew there was the test that went to the hospital, the PCR test, and the test you could do at home, which we call the lateral flow test. And sometimes you would be asked to do the at-home one. Sometimes you'd be asked to do the one in the laboratory. And that for me epitomizes what we do all day, every day, because it's not just COVID. It's every infectious disease. It's every cancer. It's every blood chemistry abnormality. It's everything that you send a test off for. We are managing the science and the performance of the test, the interpretation, and as I mentioned just a moment ago, advising on which test to do for the patient at the right time. So I always try to teach medical school, and I stick that somewhere in the lectures that I give because I worry that students graduate and don't fully realize it. They don't have to be able to do it, right? I can't do what the surgeons do. And again, in a pinch, I could deliver a baby, but understanding, especially within the medical profession, how pathologists function as a partner and another team member on the medical staff, that would be a win for me.
Well, your enthusiasm is infectious. You remind me of a story. When I was 30 years old, I had really my first medical problem. I had a thyroid nodule, and I ended up having it removed by a friend of mine. And the day after surgery, believe it or not, I walked out of the pathology lab in my bathrobe, and I surprised the pathologist and asked him to show me the slides. And he looked at me like I was crazy, but he did. He showed me the slides, and I guess maybe he enjoyed the visit
Yeah.
that I came down to, and luckily it was benign for me. But I was one of those guys. Even from Ohio, it's like, show me. I want to see the slides myself. But so, lastly, I wonder if there's a lesson from your work that has taught you that you carry with you into your daily work, every case, every day. What would that lesson be that you want to share?
So for me, it's the curiosity. I reflect on why I went into medicine and what I hope other people went into medicine to do is to keep that curiosity front and center because that curiosity drives us as physicians to ask the right questions. If I see something under the microscope that makes me pause, now I've practiced for decades. If there's something I haven't seen before, I have to ask myself, is that something that I never knew about? Is it something that I've forgotten about and have to read about again? Or is it something that I'm discovering for the first time? Because our knowledge in medicine is not static. So that curiosity is what is my lesson learned that helps keep me on top of the current medical standards, right, in my field and beyond. It helps me ask the right questions of my team as a physician leader to challenge people, not in an aggressive way, but just to ask people to pause and think, what is it that is the motivation behind what we're doing, whether it's creating processes in the laboratory to make our testing more efficient, or whether it's a particular case or diagnosis that's not fitting the textbook example. What questions do we need to ask to uncover the real truth behind that? So that's something I try to carry with me every day. And I would hope that as we teach medical students, residents, fellows, and each other, if we could all bring that curiosity to the table, I think it helps us do good things.
So true. Jennifer, thank you so much for sharing your story and reminding us that behind every microscope, there's a human story unfolding. One of the things that I'm struck with, though, in this podcast is that no matter the specialty, whether we're in the exam room, the operating room, or the lab, we're all being taught the same lesson. If we slow down, we pay attention, and we stay curious, like you're saying, our patients, our work will teach us exactly what we need to know at that moment. And sometimes the most important lessons don't come from what we see, but from how carefully we choose to look. And to you listeners out there, thank you for spending this time with us. Until next time, keep listening. Our patients are desperately trying to teach us something. And remember, stay healthy out there.
The preceding podcast contained discussions of medical cases where names and identifying details were altered to protect the privacy of individuals. The views and opinions expressed were those of the individual speakers and do not necessarily reflect the official policy or position of any affiliated institutions or organizations. This podcast was for entertainment purposes only and should not be taken as medical advice.